The topic is one of the most recent advances in respiratory care, the high flow nasal oxygen, and it's been spoken by Dr. Arindam. Sir.
So, if you don't need this friend, who are there for you, right, in situations of respiratory support. So, we have something to call the oxygen therapeutics, that means the oxygen therapy through non-ventilated ways, right, the mask and others. So, this is the new one which we will learn or which we will discuss. The second is non-invasive ventilation, where you are actually not putting but you are still giving a positive pressure ventilation, not putting the tube inside, or maybe the third one, the extracorporeal lung support in the form of ECMO or ECOR. So, these are your alternatives to conventional invasive ventilation, right. Okay. And before beginning this, how many of you are using HFNO? 3 hands only, right, but 4 hands, okay. Thanks for adding up to it. So, let us see a little bit of a disclaimer I always give, because I am neither an inventor of HFNO or innovator or a basic researcher, but what maybe I am is an experienced end user and opportunist, because someone is inventing it and we are skillfully using it and with a good morale and clear conscience, and I do not have any conflict of interest while delivering this lecture. Okay. So, very quickly a recapitulation of our Ganong-Guyton days, right, the oxygen cascade. So, it starts from a source which could be the oxygen supplier or the atmosphere and ends up into the mitochondria, right, and this is how the partial pressure of oxygen goes down from the inspired air around 150 to alveoli 100, and in the mitochondria is as close as 5 to 10 or between 1 to 20, right. You remember the cascade? Okay. The next is a little bit of why arterial Po2 is less than the alveolar Po2, because of the shunts, and we know that anatomical and physiological shunts, and because the physiological shunts, you can pretty well say this is the mismatch of the ventilation with perfusion. And let us see. So, low VQ units, actually this is a wasted perfusion, right, because there are no or hypoventilation happening. So, this is called a shunt effect. So, this leads to hypoxemia primarily in the type 1 respiratory failure, and in the higher VQ mismatch, high VQ units, there is good amount of ventilation but no perfusion. So, this is we call a wasted ventilation, and our life is somewhere in between, right, because of the 0 to infinity. And all of we know that this is the classical classification of respiratory failure or the types 1, 2, 3, 4. Particularly third is post-operative or perioperative, and type 4 is shock, right. And these are the different types of hypoxia: hypoxic, anemic, stagnant and histotoxic. And out of these three, hypoxia responds to the oxygen therapy more better. And the clinical goals of oxygen therapy are pretty simple, that you need to treat hypoxemia by giving oxygen in any form, or we said the 4 different forms or 4 different ways. You reduce the work of breathing, as well as you also reduce the myocardial work, or actually you try to come up with the balance of oxygen consumption, myocardial oxygen consumption and delivery, right. And factors that determines that which system to be used, whether depending upon your non-invasive or invasive, it applies to everyone. It depends on the patient comfort. The level of FiO2 is required to correct the hypoxia, that means low levels or very high levels, right. FiO2 to be controlled within a certain range, that means the predictable. Whatever the humidification or additional nebulization is required. The resistance to breathing, it is always good to have a minimal resistance, as well as the efficiency and economic of the using the oxygen, because nowadays are we charging for the oxygen here in Hyderabad? Yes, definitely yes, right. So, it's also you have to be very efficient and economic on using that. And factors that influence FiO2 delivered to a patient by the delivery devices is not only depends on the patient factors, but also depends on the device, the flow rate, the volume of the mask, the leak, that means the tightness of the fit, as well as the air vent size. And regarding the patient factors, it depends on the flow rate, the pause and the tidal volume, that means the minute volume, how much the patient is consuming, right. Okay, so let us see the conventional oxygen devices. We can pretty well divide into low flow and high flow devices. The low flows are the standard cannula, nasal catheters, transtracheal catheters, some are with additional reservoir because the patient can rebreathe, right. So, they can have a non-rebreathing mask or a simple mask where the rebreathing is not there, and there are high flow devices, particularly the most commonly used is the Venturi mask or an air entrainment mask, and sometimes you have some enclosure devices like the oxy hood or the tents that you use in a tracheostomized patient. So, the problem with the good thing with nasal cannula is universally acceptable, it can be used anywhere, the low flows are required, and you can see some even with the 6 liters you can deliver at around 40 to 45% of FiO2, but the problem is that if you go above this there would be patient discomfort because it is a dry air. So, normally our range is around 6 liters per minute, right, and the humidity and temperature and all these things are actually cannot be controlled, and this is somewhere in between a mask and this is the new one, the nasal mask. It gives a little bit of patient comfort, it is a hybrid of the cannula, the face mask, and does not produce sores around the nose, but dry oxygen is being given. So, this is the new kid on the block, I think almost 1.5 years it is in India itself, and it has created a very good response in the developed countries where they found. In fact, the NHS has given almost an order of almost 5,000 HFO units to be bought and bring and to be used in the system. So, its composition is pretty simple. You have an air oxygen blender with an oxygen source, right, and you need to give up to 60 liters per minute. So, the source has to be dependable. Then you have a flow meter. Now, unlike our regular flow meter, it is on a higher scale from 0 to 60, right. Then you have an active humidifier which will humidify as well as regulate the temperature of the oxygen that is delivered. Then you have a heated inspiratory circuit and a standard nasal cannula which looks a little different, right, and these are the different models that are available, but in India right now only one model is available, and but it's easily available, not that different. So, let us see that what are the physiological principles which gives the advantage of HFNO over the other oxygen delivery devices. So, it is a small loose fitting nasal prongs, it is really the material is soft. So, as well as the air or the oxygen that you are giving is heated and humidified. So, both enhances comfort. There is increased water content of the mucus because you are humidifying, optimally humidifying. So, it facilitates the secretion removal, it avoids desiccation and epithelial injury, it reduces work of breathing. High nasal flow rate, we will discuss all these things. It reduces the entrainment of the air that happens in nasal cannula or in the face mask, as well as it gives a very reliable delivery or predictable FiO2, as well as it washes out because you are giving a very high flow. So, it will wash out the upper airway carbon dioxide and it improves the efficiency of ventilation, as well as it generates a little bit of PEEP, a moderate amount of PEEP around 5 to 7. So, what you get in HFNO is that a predictable FiO2, a good comfort, right, and a very high flow which washes out the carbon dioxide and prevents rebreathing, as well as a moderate amount of CPAP. So, it is a blend between a non-rebreathing mask as well as a low efficiency CPAP machine, right. Let us see how it goes. Airway physiology, all we know that in inspiration air is warmed and in expiration the heat and moisture is recovered, and as all we know this is the ciliary function which traps the contaminants, the mucus traps the contaminants and cilia sweeps it on the upper side, so that you either you cough it out or you swallow, right, as well as there is a good amount of gas conditioning in a spontaneously breathing person. That means what exactly you are doing right now, right, you are taking a 22 degree centigrade room air, and by the time it reaches the lower airway it is 37 degree isothermic saturation with almost 100% relative humidity. So, what happens in non-invasive ventilation, the gas flows at a very high flow rate, it moves in and out of the lungs, right, much amount of moisture is lost, the patient is uncomfortable, and there are a lot of other complications also, unless you are using an active humidifier with your non-invasive ventilators. Nowadays those are quite quickly available. And what happens in the intubated airway, if you are using the HME filters, which is almost used in 99% of the patients, because we are not using active humidifiers because of risk of infection or the fear of apprehension of infections, right, it leads to lot of these complications, the tube block, impaired ventilation and gas exchange, alveolar collapse, and leading to deteriorated patient outcome. So what HFO does is that it improves the lung mucociliary clearance, and let's see this video, right. You see, with 100% humidity, see the ciliary as well as the mucous membrane, and only 10% drop in humidity for 15 minutes, see the speed of mucociliary clearance has gone down. So for an effective mucociliary functioning and clearance, you need a warm and humidified air. So that you could pretty well see the movement is pretty fine, where these are all stagnant over here. Okay, so it improves your mucociliary clearance and gives you the comfort. And this was in a 2015 trial where they tried to find out the physiological effects of HFNO compared to the non-rebreathing mask, a low CPAP, and also a rebreathing mask. And they found that HFNC or the HFNO has got one of the lowest amount of work of breathing experienced by the patient. And regarding the comfort and oxygenation, this was done on only 20 hypoxemic patients, and they found HFNO scored much better than your standard face mask in terms of reducing dyspnea, mouth dryness, overall comfort, respiratory rate, and gas exchange. And you can pretty well know that patient comfort, enhanced comfort will lead to compliance, better compliance, and better care. And this one, if you see in the face mask, right, if your flow rate is less than whatever the patient's inspiratory flow demand is, there would be air entrainment or dilution, and that will lead to your reduction in the FiO2 that you want to deliver. But if your if your flow is much higher than the patient's inspiratory flow demand, there won't be any air dilution. So this exactly happens in nasal cannula. 4 liter, maybe the patient's demand is around 10 to 12 liters. So the rest of the 8 liters is coming from environmental air, and there is air dilution, and your resulting FiO2 is much less than what you are actually trying to achieve. But wherein in standard HFNO, more than 35 or 40 or even 60 FiO2 administered is actually what is the resulting FiO2 is patient getting. That means that predictable and high FiO2 you can deliver. Also, this amount of high flow of movement, air movement or the oxygen movement, is flushes carbon dioxide from the upper airway. And you can see in this experiment, this is no flow state, this is where there is a 30 liter per minute flow, and this is a 60 liter per minute flow, and the red color is the accumulated carbon dioxide in the upper nasal airway or the upper airway, right. So this is good amount of carbon dioxide washing is happening, right, and this washout effect reduces the rebreathing of expired CO2, as well as it creates a reservoir of oxygen inside. So that means it is increasing your delivered FiO2 and allows better ventilation and oxygenation. Regarding the small CPAP effect, right, more the flow, more you have a CPAP effect as good as around 5 to 7. And this was a study by way back in 2009, and they compared with standard face mask or the nasal cannula and found, so this is the HFNO flow with the 35 liter per minute, but the mouth being closed. If the patient's mouth is open, there will be a loss of the pressure, and it gave almost around in between 5 to 7 of CPAP effect, right. Setup is pretty easy. You start with the initial flow of 30 to 40 liter per minute. We had been using more than a year. In fact, we were one of the first users to start it in India itself, and we found a beautiful result. I will show you some of the results. So initial flow around 40 liters. Main goal is to achieve whatever your desired PO2 or SPO2 is, right. Don't overdo it. Don't try to get 100%. Try to be happy with 95. And oxygen, you have the particular settings where you have to put in the humidification and the temperature. So temperature is 37 and humidification, as I told you, around close to 100%, right. And weaning is also easy when your patients gets better of the actual pathophysiology, right. You start reduction in the flow but it has to be pretty slow, 5 liter per minute, maybe every 4 to 6 hours or 6 to 8 hours. And once correct oxygenation is achieved with a 20 liter flow and with an FiO2 of 50%, then you can switch over to a conventional oxygen delivery device, right. So, it is not that difficult to win off. So, potential benefits: stable and predictable and high FiO2, a CPAP effect which gives you the alveolar recruitment, carbon dioxide flush out from the upper airways, it reduces the dead space, as well as temperature and humidification gives you the comfort. And let us see the potential clinical applications. So, obviously in hypoxemic respiratory failures, but very well used during the procedures like endoscopy or bronchoscopy even, right. And post-operatively, particularly in cardiac surgery and CTVS, a lot of work had been done, but very nicely in those two situations, in facilitated extubation, that means preventing reintubation in a post-extubated on an extubated patient, as well as in palliative care where the DNI, because even if you are conventionally using NIV in DNI patients or palliative care patients, even NIV can give you that sort of discomfort, but HFO is very nice. So, this is one of the first patient in fact we used. He had a viral pneumonia H1N1 positive traveling from US, and he was put on ventilation for 8 days, and after extubation you can pretty well see he is a pharmacist from Baltimore, and he was traveling to India to meet his family, and he done very well. This was our first patient on HFO. This was a primary lung cancer patient, 70 year, you can pretty well see the big one, and we used it for mostly because they did not want to intubate the patient. So, it is in a example of palliative care, and this was a post-renal transplant patient with a systemic blastomycosis as well as in a with pulmonary involvement, and we took a chance, and we, because of his immunocompromised situation, we tried with HFO and we succeeded to avoid ventilation, and this guy was treated without, effectively treated without intubation, right. So, HFO stands maybe in between your general oxygen therapy devices and in between your mechanical ventilation, which can be either invasive or maybe a non-invasive. So, very quickly let us see what are the trials or studies are saying. This is one of the big trial that was done by FRAT and published in NEGM, and they compared the standard oxygen therapy HFO and NIV, right, and there were certain exclusion criteria where there were urgent need for intubation or PaCO2, there were contraindications, standard contraindications of NIV, shock, GCS was low, those patients were excluded from the study, and these patients were actually intubated and also excluded from the study, because you are enrolling only hypoxemic patients who can be managed with standard oxygen therapy HFO or NIV. So, let us see the characteristics. So, they enrolled close to around 100 patients in every group, so total of 300 patients, and the primary diagnosis was community acquired pneumonia. So, they were dealing mostly with type 1 respiratory failure, right, just to remove the bias of NIV in type 2 respiratory failure. And what they found is, and the characteristics and inclusion were more or less same. You can see the respiratory rates were same, the PF ratio was somewhere in between 150 to 200, right, and most of the parameters between the groups were similar because they were randomized properly. So, let us see what was the result by Frat et al. They found that respiratory patient discomfort at first hour were reduced mostly in the HFO group, right, this is the one, and there was marked 20% reported a marked improvement in dyspnea, as well as the respiratory rate came down, wherein in the first hour the PF ratio was comparable in between two, but improved in mostly the NIV group, and obviously this is due to the recruitment which would have been possible with a higher positive pressure of NIV. But when the primary outcome, that how many patients were eventually intubated because of the failure of the treatment, they were the best results were among the HFO group. See, only 38% were eventually intubated. So, 62% were successfully treated, right. And this same sort of thing happened in HFO versus your CPAP in cardiothoracic surgery. The rates were similar, reintubation and ICU mortality. And this was on effects on oxygenation, comfort and clinical outcome. Compared with the Venturi mask, HFO did much better in maintaining or improving the PF ratio, maintaining saturation, reducing PCO2 and reducing the respiratory rate. Okay, only 2 minutes. Okay, and also it has got, see the difference between the standard oxygen therapy and HFO. Only 4% were eventually intubated, right? And this is also a situation in the post-extubation use of HFO, right? And this was the last one, Corley et al. They showed that not only HFO is improving other things. See, this is an EIT picture, electrical impedance tomography, where the distribution of, or that means the recruitment of alveoli is happening and it is being captured by the EIT videos. And see, the HFO, there's good amount of recruitment that is happening and end expiratory lung volumes are much better compared to the standard oxygen therapy, right? So HFO can be used according to the needs of the patient, cutting across all the indications, right? And it mitigates the challenge with standard oxygen therapy by giving a warm humidified gas, higher flow, predictable FiO2, and by reducing the need of intubation or even preventing your reintubation. So good clearance, good comfort, adequate accurate oxygen delivery, washout of the anatomical dead space and low level continuous CPAP, right, or the low level CPAP. So by 3 methods we may learn wisdom, first by reflection, second by imitation and third by experience, which is the bitterest, right. But still then we are Indians, we can always adapt for all our indigenous your improvements that we call jugaad, right. So we can try to help out our patients. Till then I know you are not hungry, but stay hungry for the knowledge, stay foolish and stay noble to learn from people. Thank you.